first element in the response, I think, is auto-segmentation. So the way our partners, the commercial partners, have developed and included in the clinical workflow the use of AI tools for the automatic segmentation. For now, it's mainly organs at risk, but maybe in the future it will be also target volumes. But clearly it's the main step in our clinical workflow where AI has impacted our everyday workflow. It eases the process, it standardizes and harmonizes the process, and it fastens quite hugely the process of planning radiotherapy, since it almost deletes completely the times for organs at risk delineation. Yeah, that's I think the first step. The second step is things where AI is less visible, but it's included in mainly all the recent machines, the recent Linux, for example. So adaptive radiotherapy, obviously, is a thing that is going to take more and more place in the years coming, and that has a lot of AI included in it for automatic segmentation for sure, but also for planning the treatment. So we have to plan the treatment in 15 minutes, where it usually takes us about 2 to 3 hours. So clearly, taking 2 or 3 hours with the patient on the table is not feasible. So that's where also AI is going to transform the way we plan adaptive planning. I see two main areas of challenges. The first one would be the educational perspective. We go from learning the anatomy, learning the definition of normal organs, lymph nodes area, how to delineate a target volume. And if we have a tool that does it for us, we forget how we did it before. And I think we can miss the sense of treatment, miss why the people before us did such study and why they did include, for example, a 6 millimeters CTV for several tumors and so on. So that's just an example, but I think we should not forget the historical part, and AI could make us forget this by providing us automatically volumes. So that's for the educational part. The second part would be in our everyday clinical workflow. We go from doing to reviewing, because when we do, we do it from scratch and we are sure at what we're doing. But when we have to go and review, I think it's a different work to review and not miss something. And sometimes we take too much distance from what is proposed and provided to us, and we should be very careful of this and make sure that what the AI tool, and I'm just talking of segmentation, is providing us is up to the standard that we had before. And I think that's where the black box area comes. It's that sometimes we don't know why the tool is doing, why it's doing this, and us as clinicians, we have to understand why it's doing as it is. And that's one of the challenges, and maybe one of the reasons that it's not everywhere. It's that we have to understand it. We've seen in the past, since the last 3 years, just to take this, that AI is everywhere now. And I think that in the 5-10 years, it will be even broader. We'll probably see more tools, so more efficient tools for target volumes definition. We'll probably also see tools for automatic plan generation and how it will considerably reduce the time of treatment planning and standardize it. And so that every patient gets an excellent treatment according to international guidelines, and reduce the risk heterogeneity between centers and between practitioners, and that's essential when you consider scientific data and also clinical trial, that you want to make sure that every patient gets the same treatment. So segmentation will be better, plan generation will get in an everyday basis. Maybe we'll be able to delete the CT. If we can use an MRI or a PET to plan the treatment, maybe the dosimetric CT will be overruled, and we'll need AI to get our electronic density table. That's things that on which we already worked, and other teams worked also on this, and it will definitely be an area of research in the 5 to 10 years coming. And the final point will be prediction. Prognostic and prediction will also be a major issue and major subject, because it can lead us to adapt the treatment, so either raise the dose that is delivered if the patient is at higher risk of relapse, local relapse, or even lower the dose or reduce the volume if the patient is at lower risk. So it can be in both sides, or favor maybe treatment combination with our medical oncologist partners. So definitely the future is bright, I think, for AI in radiation oncology, and it concerns every area of my specialty.